What opportunities do we have for better healthcare systems?
When we think about healthcare, we do not think about an individual patient or an individual frontline healthcare worker or a clinician, but we should look at it as a system that has multiple components. Only less than 25% of healthcare institutions in Africa have electronic medical records.
Values are part of the system.
The power to drive healing to the patient is not just on the doctor. It is shared with the patient.
But you also told us that in God we trust.
Others must bring data.
Others must bring data. Welcome to the Executive Review Podcast. Today I'm pleased to be hosting Argwings Chagwira, and he'll be telling us what he's doing in the health sector. Welcome to today's conversation.
Thank you.
It's an honor to host you. We will have some quick fire questions before we go into today's conversation. Just feel free, give me very short answers for the following 5 questions. Our quick fire question number 1 is, would you choose Brazil or Ghana for the World Cup? I know you've been to both countries.
I would definitely choose Brazil.
What excites you most about Brazil? I saw you the other day posting, was it Sao Paulo?
Yeah, I was in Sao Paulo for a research conference. I had a paper presentation, and I loved Sao Paulo.
Yeah.
But I think it is, the people there are so good and so kind. Ghana, it's very hot.
Ghana is very hot.
I didn't enjoy Ghana.
Which part of Ghana did you visit?
I was in Accra.
Accra.
Yeah.
Okay. Accra is a coastal city.
It is a coastal city.
And Sao Paulo?
Gold. Sao Paulo is it's not coastal. It's actually not very far from the forest and things. So it's a very calm city. The weather was very conducive that time. Yeah. So I enjoyed and the people are really good and they are very kind. They show you around. There's also a museum there, a football museum that I visited that was so amazing to see. Yeah. And so I would definitely choose Sao Paulo.
Sao Paulo, any day, any time.
Well, Brazil, I would want to go to Rio, of course.
Rio is the real Brazil.
Yeah, it's the real Brazil. But there is life. Now, if you think about city life, you go to Sao Paulo.
Sao Paulo. Yeah. And there's also Brasilia, that is the capital.
Yeah.
Okay. I don't know if Neymar will be playing, Neymar Jr. this time.
I think he will.
He will.
Yeah.
We look forward to. So that was a first quick fire question. Brazil or Ghana? You said Brazil. Banana or orange? This is not about politics.
Man, it's banana.
Banana?
Banana every time.
Okay, not politics. Okay, I know you're a nutritionist. You'll be telling us why bananas. And press-ups or chin-ups?
I'll do press-ups.
Press-ups?
Yeah.
Okay. Then chips or fries? What's the difference?
So we have potatoes that are air-fried.
Yeah.
I would go for that instead of deep-fried chips. So I would do fries.
You'll do fries. Tea or coffee?
Coffee.
Thank you, Argwings Chagwira. Argwings Chagwira is a nutritionist and is also into a lot more at his profession. We'll be having this conversation today. So welcome to the conversation, Argwings Chagwira. Today we'll be talking about nutrition on patient safety, strengthening healthcare systems for better outcomes. So maybe just to kick off the conversation and this episode, who is Argwings Chagwira?
It's a good question. Argwings Chagwira first is a son. And he's a young man, a lover of football. I don't play, but I support Arsenal. I love people a lot. I love hanging out with people. And I enjoy hiking and just the beauty of nature. I enjoy sunsets. And so the coffee that we talked about, I would love sunset coffees. I enjoy that so much. But I am also a health systems curious researcher. And that is probably what I am doing the most today, and some bit of nutrition consultancy. But most of the time, I would spend a lot of time just studying systems and understanding what can be changed.
Wow. So your background academically is nutrition?
Yes, my background is nutrition.
But you're also highly involved in health systems. So maybe you can just share with us your journey, career background, and what inspired you to be what you are today in the health system sector.
Awesome. Yeah, so I started off as a nutritionist. I trained in Kenyatta University in Kenya. Then I transited. My first job was a research job, and I was doing some work around antimicrobial resistance and stewardship, and also tracking infections that patients get when they're in the hospital. And I did that for 3 years, and I've continued to do that currently as a project manager. Then while just doing that work, I could see lots of gaps in healthcare systems from the data that we were generating, the surveillance data that we were generating. And so we could see some gaps in terms of patient care from how care is being done and everything. And so we started to design programs that would help address that. And that, I think, landed me to an opportunity that I'm currently doing with Africa Consortium for Quality in Healthcare in Africa.
Africa Consortium for
Yeah,
Quality
for quality
Healthcare in Africa.
Quality healthcare.
Yeah.
And what we are
I've
doing
seen you
is
call it Acquire.
Acquire.
Okay.
Actually,
I've seen it
Acquire
on your
is
LinkedIn.
Yes.
I've stalked you a bit.
Oh, okay, that's lovely. I love Acquire. I love what we do there.
Yeah.
Because that is exactly what we are doing, because we are thinking about this frontline healthcare worker who sees frustrations every day in their daily work, and thinking of ways how they can translate that frustration into a quality improvement opportunity and journey to see whether they can improve that system and strengthen patient care. And of course, that also provided me an opportunity to do a fellowship. So I'm currently a fellow with Patient Safety Movement. It is a global movement that would like to see zero patient harm in healthcare institutions across the world by 2030.
By
Quite
2030.
an ambitious goal.
That's so close. 2030 is just like 4 years or 3 years. 3 years away.
4 years away.
4 years away.
Yeah.
It's good to give yourself more time.
Yeah.
But I'll call it 3 years away because
sure.
you don't count this year. Anyway, so why is it important to look at healthcare systems from the broader perspective and rather not just from the individual perspective, especially in making sure that there are no hospital-acquired infections?
Okay.
Yeah.
While training in school,
Yeah.
you realize that these questions you're asking about quality and patient safety were not things that we were directly trained to think about actively as we take care of patients. Care that we were taught is very individualized care. And so what we thought about is, and what I was trained to do, is to look for the patient, individualize their care, for example, just assess their nutritional needs, and design intervention plans. But from the work that I have been doing, especially my research experience, taught me to look at healthcare not from an individual patient, but from the overall healthcare system. There's one guy who helped me appreciate health system from a more informed perspective. He's called Edward Deming. He's a pediatrician.
Edward Deming.
Yeah, who has written something called Systems of Profound Knowledge. And he helps us see healthcare as a system, all right? And so he talks about 4 key things. One, he talks about appreciating the system. When we think about healthcare, we do not think about an individual patient or an individual frontline healthcare worker or a clinician, all right? But we should look at it as a system that has multiple components. So we need to appreciate that. We need to appreciate that we have people within the system with different professions. We have utilities within the system. We have standard operating procedures. We have policies in that system. And all these interact they interact iteratively. And so when you look at a healthcare system, you're looking at all these components. For example, if you were to improve patient wait time, you do not just target the clinician time they spend with the patient as they're consulting. You want to think about the time they spent with the security guard when they are doing the check. You want to think about the time they spent with the cashier when they are being queued after they make the payments and things like that. And so that helps you appreciate the entire continuum of care, all right? So that you do not focus on one aspect. So he talks about appreciating the system. And then he talks about, Deming talks about looking at the knowledge in the system, all right, that we need to think about the different aspects that build up the system and what they actually mean, all right? And he also talks about the knowledge of variation, that healthcare systems produce data, and this data has different variations, all right? We have common cause variations in the data that is built into the system gaps, but we also have special cause variations. For example, there could be a system gap that is contributing to patients staying for long. Maybe we understaffed that day, all right? But there could be a special cause variation when public hospitals, doctors and nurses are on strike, and all these patients are going to the private sector and they are staying longer. So when you look at those two, then there is variation in a system. But again, he talks about psychology, that in a healthcare system, we have people. And the people are the clinicians, the doctors, the nurses, the pharmacists. We also have other support staff. We have those that help to keep us safe, the security guards. We have the finance people. All these professional people with professional backgrounds are right in there, and they are helping to build the system and make it work. And so we need to think about what motivates them and how can we support them to drive efficient and safe healthcare systems. And so we do not just target at one aspect. We think about the entire healthcare system from such way of looking at it, from Deming's profound systems of profound knowledge.
Deming's systems of profound knowledge.
Yeah.
And you have explained that so passionately. But you also have this big topic on infection prevention and antimicrobial resistance that I just want you to give us a little bit understanding about it.
Okay. Yeah. So my first job actually was to do surveillance on antimicrobial resistance. And we were looking at specific infections that patients get in the hospital. In healthcare, we call them healthcare-associated infections or hospital-acquired infections or nosocomial infections. So all those terms can be used interchangeably. And we were looking at bacteria, all right, that are resistant to treatment. But before we dive there, let us begin from data. So there's a recent publication. Actually, it was published in 2019 by Lancet Global Health. And they actually attributed 39 million. So they forecasted that between 2025 to 2030, more than 39 million deaths would actually be attributed to antimicrobial resistance if we do not take precautions. Now,
So fast forward, antimicrobial resistance is where bacteria...
So I'll get back to it.
You'll get back to it.
Yes.
Okay.
So I want to begin from us seeing the actual things, like the data. What is the data saying?
39 million deaths
39
attributed
million
to
will be
AMR.
attributed to AMR if we do not take precaution. All right? And by 2019, 1.39 million deaths were directly attributable to antimicrobial resistance by 2019.
By 2019.
Now, this statistic tells us that we need to take precaution. But you know, when we say antimicrobial resistance, it's a very biological term, and we would think this is something that doctors should just care about.
It's a doctor's thing.
Yeah, that is what we would think about.
Yeah.
But everybody participates in contributing to this endemic, all right? And it's growing so fast. It's a global issue. It's actually a WHO priority, all right? There's a lot of funding going into driving stewardship so that we prevent antimicrobial resistance. But what is it, really? You know, in school we used to talk about germs, and germs include bacteria, include fungi, include viruses, and protozoa, all right? And when these germs become stronger than the drugs we have, that is what we call resistance. It means if you take that drug, it won't be able to treat you. That's a problem.
It's a problem.
And what has happened over the years, it's actually our contribution. Let me begin with agricultural
Would I
sector.
say that is like a form of mutation of these germs?
Yeah, there's the gene part of it,
Uh-huh.
all right? But because we gave it the exposure, and the exposure that we gave it, it is so much into our behavior. In 2019, COVID came and everybody was getting a regimen to treat the virus, and part of it was azithromycin. And I think people learned about azithromycin in 2019 a lot, in 2020.
During COVID.
And nowadays, every time someone has a cough, they are asking or they are going straight to buy azithromycin. A cough is mostly viral. It can be bacterial if it is tested, but it is mostly viral. An antibiotic cannot treat that. All right? Yeah. It is treated by an antiviral medication. And so our behavior has led to the resistance. And how has that journey been? It is when we have walked into a chemist and bought antibiotics without a prescription. It is when we have borrowed an antibiotic that our neighbor is using. Do you see when you just knock and ask, please, do you have this drug? Do you have azithromycin? All right. It is when we've not finished our doses.
Yeah.
You know, antibiotics and just any drug really. If the doctor has prescribed and he says you need to take it within this time, you actually need to take it within that time. Yeah. You're not supposed to share it. Yeah. It is when we have, in our healthcare institutions, not invested so strongly in infection, prevention, and control, what we call IPC. Because when we don't invest in infection prevention and control, we provide breeding grounds for these resistant bugs. They are right here with us, all right? And if we do not take care, they're actually here to stay. And so what is this that we can do? It is now doing the opposite. Stop taking antibiotics for viral infection. Yeah. And you know, it is even going further to stop coercing a doctor or pushing a doctor so hard to give you an antibiotic. They know what you need, they will do the diagnostics, and they will know you need this medication. You need to trust that. And of course, you will discuss with the doctor about it. And the agricultural sector have also misused drugs. And so this is not just a problem in healthcare, but antimicrobial resistance is being talked from a One Health perspective. How is agriculture contributing to it? What are the practices there? Because we have veterinary medicine and we have antibiotics being used there. And then we get to consume the products. We take the milk, we take the meat, and again, that builds up the resistance. And so investing in infection prevention and control would include just things like hand hygiene for healthcare workers. Wash your hands before and after seeing a patient. Wash it for at least 2 minutes. I mean, there are steps that WHO has outlined. And every healthcare institution needs to look for those infection and prevention and control guidelines. Have them in your institutions. We have very adaptable guidelines. Actually, Kenya has specific IPC guidelines that a healthcare institution can adopt, and they can use it to find out strategies on how to track that. In Kijabe, we have actually been tracking hand hygiene, and we've improved it to over 80% for the past 1 year.
Wow, that is so good. So I think what you're talking about, the healthcare system, it involves even me and my behaviors around safety. So the systems are also behavioral. Behavior is part of systems.
Behavior change is what drives and improves systems.
Yeah.
And we'll talk about that in detail, I know. But do you remember when you visited a healthcare institution and you saw they've written a post and they say, do not sit on the patient bed?
Yeah.
Exactly. So when a patient is there, they're vulnerable.
Yeah.
And you're carrying germs with you, right?
Yeah.
On your clothes, they're everywhere. The rail where you're touching, even this seat has some germs here. Yeah. And so that patient immunity is actually very low. So if they get that infection, it means they will stay in the hospital longer, so healthcare cost will definitely increase. They will affect their organs. Some antibiotics are so strong that they affect body organs.
Yeah.
If the patient takes them, it means you are likely even to carry them at home to your children.
Yeah.
Because young children, again,
Vulnerable.
are vulnerable to infections. And in case it's very hard to treat,
So it
someone will die.
becomes is it now, pandemic is a big word, but it becomes a common thing now.
I mean, if we
becomes
don't do
difficult to
something,
contain, yeah.
AMR is almost a pandemic.
It's almost
for
a
sure.
pandemic, yeah.
Yes,
It's that serious.
it's that serious.
39 million is a big number. So let's talk about surveillance, and there's a role that surveillance plays in just making sure that we are getting better healthcare quality in our systems. Can you help us just look at the role of surveillance in sorting out the mess that we have behaviorally and structurally in health systems?
You know, when we talk about surveillance, there's a quote that I like using. In God we trust, everyone else must bring data.
In God we trust, everyone else must bring data.
Exactly.
Okay.
So when you talk about issues about your healthcare system with no data to justify what you're saying, you are like what we say in Swahili, unapigia mbuzi guitar. You are actually playing a guitar to deaf ears. Because data is what helps us improve systems. It is what tells us this is where the gap is. And it is what tells us this is where we need to begin from changing. And I mean, it is really built into what you're doing daily. It is what you are generating. And so surveillance is basically looking at what I am doing and what data am I generating and how can I make use of this data to drive change. Where should I begin from? We have had a journey generally in Africa in terms of building surveillance systems. And we still have a lot of challenges because when you think about surveillance, you want the frontline healthcare worker to actually be the one doing it. But remember, they have an already existing jobs. But we do not want to take quality care and quality improvement out of someone's job. And so evidence-based medicine wants us to interact actively with the data we are generating every day to ask ourselves, is this data speaking to the care that I am providing? It's not an isolated function. And so I wouldn't want us to think about surveillance like we should employ someone to actually come and generate the data and collect the data I'm generating. It is what simple tools can I use? Is it an Excel that I can use to key in the data that I am generating every day? Because every day you cure a patient, every day you give a medication to a patient, that is data you're generating in your healthcare system. But what does it mean in terms of patient care? Is the patient frustrated with the time when you're keeping them? Is the treatment you're giving working? Are patients coming back with similar complications even after you have given them that medication? And that is the data that helps you to know, okay, maybe I need to pause and reflect whether what I am doing is evidence-based or it is fear-based. Because fear-based care is you are just afraid of an outcome a patient will have, and so you will want to just continue doing the normal without reflecting on the data that you are generating. And as I've said, with more than, because even currently as we are speaking right now, only less than 25% of healthcare institutions in Africa have electronic medical records. And so most of healthcare institutions across Africa, it's not just a Kenyan problem, they have paper-based records, and it's very hard to track back on paper. We lose this paper sometimes. Of course, it's very hard to track back and get the patient data. But if you have an EMR system, all right, you are able to sort of like integrate the systems and see what is happening here, what is happening here, or even aggregate the data together and see if you are doing this intervention, what impact does it have to this specific outcome on the patient, and does it benefit any other outcome of the patient? In terms of AMR, we have had some bit of progress. The National Public Health Lab has tried to integrate susceptibility data across different institutions in Kenya, and it is helping us see currently resistant trends in Kenya in terms of the antibiotics that are being given, and that has been a milestone, you know, all the way up. But on the grassroots, like right there at the front line, when we think about health systems, we need to think about the nurse we seeing the patient. Is my care actually, does it have an impact to patient care? I do surveillance for hospital-acquired infection. And the question I would have even for a patient assistant is, if the environment that I'm supposed to clean, all right, they swabbed and it grew a bacteria, meaning it contributed to the infection, did I do it well, and should I actually improve? So surveillance, it is what we are generating, and pausing and reflecting and asking, can I improve from what I see? And decision makers in healthcare want to see the graphs. They want to see the data. They will not trust your theories.
They want to make decisions out of evidence and not fear.
Out of evidence.
And since these are human beings, they must come with evidence. So you said, in God we trust, but everyone else
must bring data.
So Chagwira, let us just also look at the challenges that are facing the surveillance infrastructure and the surveillance structures in our healthcare systems.
Yeah. You talked about infrastructure and you talked about structures, and the challenge begins right there. We need to think about building these structures and what infrastructures to work around these issues. One of the things that we are struggling with is just digitizing healthcare, because data exists in the paper, so it has not been translated into a usable format, and also data is existing in silos, so it's not iteratively interacting in our healthcare system. So just aggregating this data is very important. Building such infrastructures can happen locally using simple tools. Like I mentioned before, an Excel can be useful to do that, to even build a simple dashboard on an Excel, all right? So we need to start thinking about applying data science knowledge and strengthening that in healthcare. And that is probably one of the challenges. People are not thinking about the data they are generating every day. So that advocacy around pause, reflect on your data needs to actually happen. And building good infrastructures require resources. We are low and middle income countries, man. We still struggle with the resources needed to build different infrastructures and to work around systems that would help clinicians to reflect on the data.
So invest in resources, mobilize resources to build the infrastructure, but also close the gaps and make sure that the system is integrated. It's integrated. Very good way to look at the challenges, but I believe these are challenges that can be solved. We just need to put our act in it. I would want you to just embark a little bit on something you allured to earlier on this conversation. That is patient safety being central in our work, but also getting to know what this means to you as a healthcare worker, and also what it should mean to all of us, even outside the profession.
So one of the landmark publications that everybody listening to me should actually read about patient safety is a publication by Institute of Medicine in 2000 called "To Err is Human." So they looked at US data, and we had many deaths that were directly attributed to patient safety concerns, meaning if we did something about them, the death would have not occurred. All right? And before, as they were tracking to see what should we do about it, it was a very punitive way of handling the cases. So it was blaming people, so shifting blames. It is you who caused it. It is you who caused it. All right? And not looking at the entire healthcare system. That publication created a mind shift from a blame culture to asking institutions and healthcare institutions to think about how they can first build a patient safety culture, and secondly, by building a patient safety culture, is helping every single staff have this audacious goal of zero harm to any patient, but also to provide a psychologically safe environment where in case an error occurs, you report the error without thinking that you're going to lose your job. And so in that paper, the big news is if an error occurs, it shows a system gap, not a person gap.
A person gap.
All right? So in case there's an error, we need to audit the entire healthcare system to ask each other, what was the vulnerability in this system that we need to strengthen? And so what does patient safety mean to me? I'm a patient safety fellow. And patient safety movement want zero harm by 2030. Audacious, again, because we have many patient safety concerns, all right? But patient safety to me means thinking about a patient, not necessarily as a patient like we are calling him right now, but as a human. When someone walks into your clinic, they have come because they trust you will help them. You don't look at them as malaria or as this mass that is growing on their neck that I need to excise.
You look at them as a human being.
You look at them as a human being.
Yeah.
And Dr. Lackman is a global patient safety advocate and expert, has an amazing paper that he narrows down to thinking about the patient as a human, all right, and building healthcare system strongly founded on human values, compassion, kindness, all right, so that empathy, so that it is grounded on human values, and that value is how you now treat the patient. And the question you ask yourself as a clinician is, if this was me, would I treat myself the way I have treated this patient?
Yeah.
If this was my mother, would I do the same way? Human values, value-based systems rather, is what will drive patient safety in healthcare institutions.
Human values. Values are part of the system.
Values, we need to drive them in the systems.
We need to drive them in the system.
Because why would a surgeon be so tired and still go ahead and operate on someone? But again, there's opportunity that we need to look at. Even in Kenya, there is currently, by Ministry of Health, a Quality and Patient Safety Act that has actually been passed through Parliament. I don't know if you know about that. A document that you should actually read, and everybody should actually read. It's an amazing document that talks about patient rights, that talks about what quality and patient safety looks like in Kenya, the Kenyan landscape, and that talks about future opportunities in patient safety in the country. And these are opportunities that patients need to actually look at. And you know, offering that care requires you to think about equity in healthcare. And equity means shared power, where the power to drive healing to the patient is not just on the doctor. It is shared with the patient. You both are co-producing the care. The patient is saying what they feel and also what they want after you give them options of what you need to provide to them.
You need to give them options and respond to their feelings and their wants in a human way.
Yeah.
Driven by values.
Exactly, but drop the power as well. So you are not a demigod.
Okay.
You're supposed to let the patient be a part of the journey, because in quality improvement we began from there are levels, from quality assurance, where you just look at you meet whether or not you meet the standards, to quality improvement, what we've been talking about, how do we make use of the data we are seeing to improve. But where we should actually journey to is where we can co-produce safe care together with the patient, together with the other staff. We sit together and think, how can we make this care safe for you and of quality?
And of quality. And talking about quality, let's just look at how quality improvement, being a continuous process, can be implemented at local level in our various households and small facilities, and even the big ones. How can we ensure there is continuous quality improvement in our healthcare systems? And probably you can just suggest simple examples that are practical, that are doable by everyone.
Okay. I am a quality improvement coach. So I support teams to drive quality improvement in healthcare. And every time someone comes and we are beginning to start, the question I ask them is, what frustrates you?
What frustrates you?
Yeah. So in your daily work, what frustrates you? I know you're in business, and even in business, there's something that is frustrating you.
Yes, they always pain points.
Something so interesting, by the way, you should know about quality improvement. We actually borrowed a lot of these processes from manufacturing industry.
Yeah.
It is from Toyota and what they were doing. It is from really manufacturing industry, borrowing that ideology and bringing it in healthcare. It did not primarily begin in healthcare. We borrowed it from aviation. What frustrates you as a healthcare worker? As you sit there seeing the patient, what is this that if you change, you will feel better? And that is a good beginning point, because you begin to think, then what data do I need to collect to justify that this is truly a frustration? And then what is the science that I need to actually employ to drive this specific change? Which team do I need to begin with? And we have many teams that I have supported and we are working with to improve healthcare. We have a team that is working on segregating waste, just putting waste in the right bin. That was their frustration, and they are driving that change. We have a team that looked at healthcare workers and they were not practicing hand hygiene, and they're improving that compliance to hand hygiene practice in healthcare. We have a team that is concerned that when a patient comes, they take so long on the cashier queue. And that keeps the patient for so long there.
Yeah, it
and
becomes
they want
a frustration point.
Yes,
yeah.
They want to reduce the turnaround time for a patient from the time they arrive at the gate to the time they get queued to see a consultant or they get actually triaged. And we have a team that is thinking about parking. Security thinking about parking cars to help patient transition from parking to getting to the gate. And so
actually,
what frustrates
there's a famous
you?
private hospital here in Parklands that everybody knows about. It has the best quality services.
Yeah.
But on parking, you can take a whole 1 hour just looking for parking.
I mean,
it's a big name, but parking
is a problem.
It's a problem.
So that is wait time. You see that time you take moving around trying to look for parking? If you have a patient who is an emergency, they can actually die in the car, right? They can complicate in the car. And so what is this that frustrates you? For me, that is where it begins from. Yeah. And what can you do about it?
And what can you do about it? The small things. And that it's part of quality development.
Quality improvement.
What frustrates you?
What frustrates you? Let me tell you something.
Yes.
I'm in quality improvement, and I stood on a weigh scale when I went to donate blood the other day, and my weight frustrated me.
It did.
It did. And so what I decided to do is to design a quality improvement program to help me.
But you're doing better. The last time I met you, you are a bit more chubby.
Exactly. So I was like, okay, so I am actually baseline obese, and I need to reduce this. And not because I am a nutritionist, but because it
frustrates you.
me. I know that I do not need to get communicable diseases.
Yeah.
And I have to work on improving myself, right? And applying the science I know of improvement to see this change. And so the link between what frustrates you to what science of improvement do I need to improve, I think that is what we need to think about actively as we engage in healthcare.
Okay. Now, I want us to start winding down this conversation. Let us come back to Africa, Chagwira.
Yeah.
What opportunities do we have for better healthcare systems? What excites you most about the opportunities that we have to sort out our challenges? But also, what challenges are most urgent that, if not addressed, we will have this menace for a long time?
Exactly. Now, let me begin from what I have said. And from an intrinsic opportunity, your frustrations. That is an amazing opportunity. And if everybody thought about their frustration, everybody would want to be a quality improvement self-leader where they are working. That is the first opportunity.
It doesn't have to be an hospital. Everywhere.
It is everywhere.
Yeah.
Of course, I've said there is manufacturing industry, there is aviation industry that is using the science of improvement to improve healthcare. So that frustration is the beginning point. Do something about it.
Do something.
Right? There are many opportunities that we have. I mentioned an institution like Africa Consortium for Quality Improvement. Just check their website. They have amazing programs that you can apply to and get trained on the science of improvement to turn your frustration into an improvement project. We have ISQA Africa, which is more like an international body of quality improvement.
That is ISQUA.
Yes.
Okay.
Yes. And they have amazing webinars they run to just help drive that quality improvement curiosity. We have Society for Quality Improvement in Kenya. I mean, you see, the curiosity growing so much that everybody is actually trying to drive change. So Society of Quality Improvement in Kenya is actually designing opportunities for healthcare workers to just dive in and be a part of this conversation.
Wow. And what would you tell your younger professionals who are still in school, coming up in this career, and the many people who are aspiring to join the health profession in regards to ensuring there is better healthcare systems, there is limited hospital-acquired infections, and there is continuous improvement in our systems?
Yeah. Stay curious.
Stay curious.
My journey is curiosity. I was doing one project.
Curiosity brought you here.
Yeah, to help study antimicrobial resistance and just get the data to see what it is saying. But I began questioning the data that I am seeing. It didn't make sense to see that blood is collected and it doesn't grow anything, and the patient and the doctor is struggling to know which medication to give. So curiosity is one of the things that should really be a part of you. Like, it should drive you every day. Secondly, I know this is repetitive, but don't ignore your frustration.
Don't ignore your frustration.
Because that is an opportunity to improve care. Don't ignore your frustration. It's an amazing opportunity. And lastly, it is human values. You know, we can talk about quality and safety and forget that we need to be compassionate, and forget that we need to be empathetic, and forget that we need to be kind. If you have any opportunity, just know the greatest one that you have is to be kinder. Yeah.
The greatest one that we have is to be kinder.
Yeah.
In values. Where do you see us in the next 5 years as a community in terms of healthcare systems, even as we close this conversation?
Man, I see many healthcare workers driving change.
Many healthcare workers.
Many healthcare workers driving change. And we have a growing curiosity of even young professionals thinking, we want to be a part of this. Yeah. And they're looking for opportunities. People are not just okay with their daily routines, like this is what I'm supposed to do until 5 p.m. or until 6 p.m. We have people who are questioning what they are doing. I am, because I'm going to dive my head in and get into the work, I'm looking forward to seeing many African healthcare professionals driving quality improvement, providing safer systems, and most importantly, I am eager to see how the patient can be a voice in healthcare.
Thank you so much, Chagwira. I think many people would want to connect with you. Maybe you can just let them know. Personally, I met you in school in Kenyatta University, but also we keep in touch a lot on the LinkedIn. I don't know if that's the platform you want people to get in touch with you.
I'm pretty much available on LinkedIn. Just message me and I'm happy to respond. My Argwings Chagwira on LinkedIn. Primus Nutrition is also on LinkedIn if you have any nutrition need and you'd like us to support you. My email is amcdata15@gmail.com. If you have any research question that you'd like us to connect and engage, feel free to connect with me.
And Argwings is always busy blogging on LinkedIn, educating people, going out curiously to know what's happening out there. He loves traveling. I see him traveling quite a bit. And it's been a pleasure, Chagwira, having you on the executive review, having a conversation about our healthcare systems, looking at how we can strengthen them and also improving them. And we have discussed quite a lot, from values to surveillance to reducing hospital-acquired infections, to getting curious, to connecting with one another, to reducing the silos, the disintegration in the manner in which data is arranged, and making sense out of data. And you've told us that we must address the pain points. What frustrates you? That's the starting point. But you also told us that in God we trust.
Others must bring data.
Others must bring data. Thank you. Keep it. Semeza TV, the Executive Review Podcast. I am Rick Okinda. It's been a pleasure hosting you.
And
makes me a pleasure.
Been a pleasure.